Welcome to the Walk in the Park podcast, the official podcast of the Lead Up Task Force of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. In Season 1, we will be taking a look behind the curtain of the C-suite, sitting down with individual CEO, CMO, CFO, CNO, and COOs of a diverse range of physician practices and hospital systems. Please remember to hit the like button and subscribe to stay up to date on the latest episodes. Enjoy the show. So today we welcome Dr. Peter Pronovost, MD, PhD, Fellow of the American College of Critical Care Medicine. He is a prominent patient safety advocate, physician executive, critical care physician, and researcher with over 1,000 peer-reviewed publications. His quality work has earned him national recognition, including being named one of Time Magazine's 100 Most Influential People and receiving a MacArthur Foundation Genius Grant. He currently serves as Chief Quality and Clinical Transformation Officer at University Hospitals Health System and Professor at Case Western Reserve University. He has co-chaired a healthcare quality summit in response to a White House executive order and served on numerous advisory groups for patient safety. He previously worked as Senior Vice President for Patient Safety and Quality at Johns Hopkins and founded the Armstrong Institute for Patient Safety and Quality. He advises the WHO and Congress on patient safety and has founded multiple healthcare technology companies. Welcome to the show, Dr. Pronovost.
Great, and Julie, call me Peter, and thanks for having me.
Absolutely.
And
It's our pleasure.
we're really excited to have you, Peter. That was a great introduction, but why don't you tell us a little more about yourself? Give us a little more background if you like.
Yeah, sure. I got into quality and safety pretty ignobly when I was a fourth year medical student. My father died of a misdiagnosis. He should have had a bone marrow transplant, but they didn't get his cancer right earlier, and he died pretty horribly in pain. With the palliative care nurses saying, "Oh, he's had his limit of meds, pain meds. We can't do," which is obviously we know how absurd that is now. And Ross, it's interesting because I believe deeply that the secret of great care is love, and love is this energy that is within and connects us all, that we're all worthy and capable. But that story was ironic because when I went to med school at Hopkins, and when I applied there, one of the senior docs on the admissions committee looks at me and said, "Why would I let you in here? Because you didn't go to an Ivy League college, right?" And admittedly, I was like a sports and a social in high school. I wasn't super student. I went to Fairfield University, a Jesuit school, and my dad went. And I looked at him and said, "You're right. I didn't go to an Ivy League school, but the only objective test that we have is our MCATs, and I, scored like 99.9% in the country on them. So if you believe in evidence and science, you'll let me in, but you need to choose what you believe in." And like the guy was like, "Whoa!" And so I got in. But the beautiful thing is, when my father died, I went to talk to him because I was going to have to drop out because I didn't have money, and there was no loans to get. So I said, "Hey, I'm going to have to leave my fourth year med school until I could do something," and he waived my tuition.
That's an incredible story.
So anyway, I went into healthcare. I did my started in emergency medicine, trained in anesthesia, fellowship in critical care, did a PhD in outcomes research. And I was, like a lot of young people, I was working on, being a great clinician, first and foremost, what's most important, and then publishing. And when you have tools, publishing is easy. I mean, like it's just like there's a technique, you do it great, but it wasn't feeding my soul. And then a adorable 18-month-old girl called Josie King died of eclampsia at my hospital, and she looked hauntingly like my daughter, kind of freaky. Was born like one day around her, but she died on my birthday, and her Mother Sorrell, amazing woman, heard that I was working on safety, and so she asked if we could meet. And I met with her and said, "Could you tell me that this won't happen to my other two daughters?" And as Ross and Julie, as leaders, when you get put in that, our natural response is to tell how great we are. We got this solved, right? Oh yeah, no, we're doing. We this, and I had this like moral moment, and I paused and I said, I can't tell you that your daughters are safer. They're not. At the time, our rates were sky high. We didn't have a good program. We had no accountability. We aimed for being average of the CDC, which was, people using the checklist 30% of the time. But I said, I will. And that kind of, launched this career of eliminating those at Hopkins, and then next in Michigan that we published in the New England Journal, and then spreading it state by state across all the US and reduced infections by 80%, and then in 5 other countries. And now kind of taking that same approach at university hospitals, but rather than working on one health problem, developing a model to transform healthcare, or I'd say to elevate healthcare, that we get rid of defects in value more broadly. We say, meaning physical harms, complications, suffering for weight or disrespectful care, inequities, so variation in care by whatever group you want to say, and then waste, which is, bankrupting patients and bankrupting the country. So, through all of it, it's been, this passion of how do we create scalable models to solve problems in healthcare, and test them and then deploy it. But what underlies it is this deep belief that people are good, that our clinicians are worthy and capable. And when we bring worthy and capable people together, we solve problems better and faster, cheaper. But, Ross and Julie, too often we don't. The opposite of love is separation. And we often, have executives come up with ideas that are trying to tell a general surgeon how to do something, right? And when we don't get frontline people's ideas in, we make ideas that are uniformly wrong. And if they aren't, they're often not implemented because we don't have buy-in. And if they are implemented, they sometimes or often will make it worse. And so we have to create this culture where we value and honor everybody's voice. As an executive, I have, in a critical care things, I have things that I see, but the reality is my job is mostly to say why we're doing something and what the goals are, and partner with frontline clinicians to figure out how. And when I get excited, which admittedly I do, but I put my pause in the how, it's often wrong. And I have, my colleagues like Peter, don't get excited. We got this. We're the ones at the front line. Let us figure it out.
That's all incredible. I mean, the story itself is incredible. The passion. I mean, if people need to ask why we have you on, like that short, just little discussion there, that little story you told us, and kind of how you got where you are, and the energy and enthusiasm you're showing is why we wanted to have you on. I think really this is going to be great for our members, because we're already seeing kind of the veil of how you're approaching things, and why it's important to have people like you with the understanding from a clinical background, but also in these areas to affect change.
Right.
So
Hey, Ross,
now,
if I could just
yeah,
build on that for 1 second,
sure.
because I know you said you're happy to have me, and not just because I'm friends with Lena. I'm honored to be here, because seriously, like, healthcare needs your organization. Like, we need your docs, because we've have really big headwinds coming, as you know. I mean, after reimbursements being cut for docs, and supply costs are up, labor costs are up. We're going to have more uninsured. Tariffs are going to make supply chain, and we're not going to cut our way out of this. Like, we've been approaching this through a mindset of scarcity. Yes, we had overhead, we needed to make those. We're going to innovate our way out of this. And innovation is going to come from bottoms up solutions, where we have a culture that allows the free flow of ideas amongst your members, or amongst different organizations, or even other industries to learn. And it's I hope we have your members inspired to solve problems in healthcare, because that's what our patients are going to need if we're going to have sustainable healthcare systems.
No, I mean, I could not say that better myself. I think you actually hit it right on the head about what we have to face.
It's a pretty spectacular kind of path to where you've landed now. And during that transformation that you took from being a medical student who was dealing with these kind of overwhelming family healthcare issues to going into clinical practice to becoming a C-suite executive, what would you say are some of the pearls or key takeaways you've learned along the way?
Uh, yeah, so many. I would say, probably most importantly, Julie, the most important values or principles that guide the work are being humble, curious, and compassionate, uh, respecting, appreciating, and helping others, and being accountable to continuously improve myself, my organization, and my community. Right, and that I mean, it may sound trite, but like values like excellence are the output. You don't get excellence if you're not humble and curious, right? Where you're looking for ideas to solve problems. The second thing, Julie, is I would say um, have the courage to think boldly about solving problems, right? Too often we focus on like that one technical problem that I'm dealing with or in my group. But what we should be thinking is when you're working things, what's these bigger problems in healthcare that if you're facing it in Chicago, we're facing it all around America, or if not the whole world, and thinking of prototypes that could be scaled. Yes, you have to solve your problems, but if you have a framework or a prototype, then you could scale it. In other words, and prototypes don't have to be rocket science. It's like make a damn checklist, right? But it's a tool that allows you to then codify it. The other point, uh, Julie, that is really key is, too often we think leaders is having all the answers and telling other people what to do. And then junior people get so fixated on getting formal authority. So who's going to report to me, right? I need, and that's my power. And I've come to learn that formal authority only allows you to do two things: call a meeting and pick up the check after dinner. Nobody follows you for formal authority. They follow you because of your vision and because you're caring and competent, right? I mean, you see that a lot of times, like 90% of the work that I'm doing and like spreading programs across the country, I didn't have any formal authority to do that. I had perhaps moral authority to say it's not okay that we kill little girls from infections. Like this has to, this has to stop. But rather than thinking leadership is the answers, what I would say is leadership is the courage to ask the question and the commitment to convene a team that could figure it out together. Indeed, again, in my life, the way I define leadership, and I don't pretend it's right. There's a million. Everyone does it their own way, but for me, it's really simple. It's leadership is the ability to bring people together to solve problems that makes the world a better place. Like that's what leaders do or should be doing every day. And it's comforting because what it says is I used to think I needed to have the answers and I almost never do. So I may not speak up if I didn't have the answers. And as you can probably tell, I stutter pretty badly. Sometimes it gets much worse. And so I used to be reluctant to speak up. And then I kind of got this comfort to say, I just have to say, this problem's not okay. We need to work to go fix it and bring the collective wisdom. Because almost every time we solve problems, when you bring the people together, the technical solutions are easy. It's the cultural buy-in about, who's threatened by the power, problems. And so we have to be mindful of the adaptive problems, which are the buy-in. And, I'll share with you both the story. So let me go. So the lesson of that is one of the biggest mistakes leaders make is they try to solve an adaptive problem, which is buy-in or culture, with a technical problem. And like, so what's the science or what's the evidence? And I'll share with you, when I was spreading the CLABSI projects, we would go state by state, and every state, the State Hospital Association would host a meeting, and every hospital would send a team. So there's maybe 400 people in the room, and I'm in this room, and I won't share what state it is because you may know, but there was a trauma surgeon in the back of the room with his arms crossed, and and he just wasn't looking like a happy camper, right? And he's from the big academic center in the state, and I get I'm an outsider, like what the hell are you coming into my state for? So I start talking about how we're going to reduce eclampsia, and he screams out like 2 minutes into my session, "This is just a bunch of crap!" Like 400 people there. So the person hosting is like, "Okay, do we go escort this person out?" And I said, "No, no. Like this is the adaptive work that we have to go through. Let me just talk to him." So, well, what's your name? Dr. Jones. Okay, Dr. Jones. Why is this a bunch of crap? And he's like, because your stupid checklist says, to use full barrier drape, and there's no difference between 3/4 drape and full barrier drape. And now my hospital is putting that in everywhere in our damn hospital. And I said, Dr. Jones, you're spot on. There's no evidence that full barrier is any better than 3/4, but we know it's a lot better than the little squares. And we used to harm a lot of people from those little squares. So if you're putting a central line of meat, I hope you use the full one. But you're right, there's no evidence. But I was trying to understand what his adaptive challenge right? And I think it was power and control. So I said, "Okay, but Dr. Jones, help me. Like, I want to understand what's getting, like, you're in an uproar, because the difference between a 3/4 drape and a full drape is like you grabbing the edge and flip it. We've argued more now than you could flip for the next 2 years. So I don't think that's what's getting your crow up. I think there's something else that's bothering you. Just curious to see what it is." And he looked stunned and he said, "Well, you're right. I just wanted you to admit publicly in front of everyone in this state that there's no evidence between 3/4 and full. But now that you did, I'm happy to use the full." Right. And it was like a stunning example. The evidence was, the science wasn't the problem. Right. This was, I needed to genuflect. I get it. He's a senior guy, wants to be respected. Like, I'm out from the outside. He wants to show his peers how smart he is. I totally get it. But like, without that humility, we could have got into this, pissing contest of, debating the evidence. But most of these debates aren't about the science. The science, for the most part, is pretty easy. You put reasonable people, you're going to figure it out. It's the buy-in and the culture piece that we get that we get caught up. So those would be some of the things. And then Julie, one final one, and it may sound simple, is probably the most important leadership trait that I think is under-recognized is to stay grounded and mindful, because once you get, you start focusing on who's right rather than what's right, you lost the ability to solve problems, right? And I can't tell you how many times in the ICU, someone would come in, or in the OR as an anesthesiologist, and with all due respect to my surgical colleagues, someone said, "You anesthesiologists are all lazy," right? Like, like a generalization, and you just want to go home at 3, and I get that, but I said, "Okay, well, you look like, you're upset. Help me understand what the issue is. You guys are just all lazy. You just want to go home." I said, "Okay, I get it. That's not helpful. Help me understand what is really got your goat." And what was clear is that doctor had no insight, like, of their emotional control, right? And he's losing his ability to solve problems, as you often see these fights all the time. And so, I God knows I learned how to do this, but staying grounded in the moment. It's just like, this isn't a talk on meditation, but it's really key to say, okay, I'm ineffective as a surgeon, and I'm ineffective, as a leader when I'm screaming, that I got to take a breath or whatever I need to do to stay grounded, stay focused on the problem I'm solving. And, I was, to give you an example, I was sharing this with all the surgical chairs at my hospital. And one of the chairs said, "Yeah, but Peter, when you're in a stressful situation, you have to scream." And I'm like, "Okay, like there's compelling data that you're impaired. Like, you might as well be drunk, because you're not thinking wisely when you're that emotionally charged. You need to be like the Zen master to stay grounded, focused, and in the moment." And then, Julie, one final thing that I would say is, value the dissenter, or assume positive intent. So often when we're leading change, we believe in it, but we risk flipping from thinking we're right to being righteous. That if anyone disagrees with me, I'm right. My executive C-suite does this all the time. So this isn't just, like that, in clinicians where they want to put something in. If you or Ross are saying, "I'm not," there's risks. I don't want to do this, we assume that you're lazy, whatever, like, you don't want to work, and we bulldoze you over, and it never, I mean, it's these unnecessarily fights. And so what, value the dissenter or assuming positive intent means that when I see you resisting something, Julie, my response, and again, this is why I go back to the secret of great care is love, that people are good. I say, Julie, I know you want great care, and so do I. And so I wonder if you could help me understand, what do you see as the risks with using this checklist or making this change? Because you're a really good clinician. If you're worried about it, there must be something that I'm not seeing, and help me understand it. Right. And when framed that way, from a mutual respect, it's, I mean, literally, I would say 80 or 90% of the time, it's, oh, I just didn't know that's what you really wanted. But when you clarified it, I'm happy to do it. Or also a real time, you would say, yeah, Peter, I get you want to do this, but this imparts an unintended consequence. There's some other downstream risk because I'm doing this, so I can't do that. And then it's, okay, Julie, wow, really insightful. How could we solve both of those problems together, right? I don't know if they're either or. Could we defend against both of those risks? Because anytime we change a system, we may protect against risk, but we inevitably put new ones in. Thanks for raising it. Could you work with me to solve it? And framing problems like that, but that's not how we solve problems right now in healthcare.
That's not how we solve problems right now in general.
Yeah, good point. Yeah, good point.
Thank you. It's very insightful.
Yeah, no, and I laugh because you guarantee you that now every one of our listeners is now thinking of who that trauma surgeon could be, because we probably
Yeah,
have a
I
list
figured.
of like two or
That's
three
why I
people in
didn't
our
say the
head.
state, and you'd probably
Like,
guess it.
yeah, I could go, well, there's probably a few we could probably pull from. That's the problem. But speaking to a room full of surgeons, obviously it's not a surprise. But that's actually a good example, a good segue to my next question, because that wasn't the ideal way for that surgeon to approach a problem. So, screaming out in the middle of a room. So, what advice would you give? So, for our average, listener, or the residents or the trainee, students, the fellows, if they want to approach someone like you or someone in the C-suite with a bold idea, which you mentioned earlier, they came up with, they have a way of doing it. How do you recommend they approach that? Rather than, now we've known how not to do it by screaming out in the middle of a room, but what kind of advice would you give on how to even start that process of bringing that idea forward so you don't hit that brick wall and can move things going?
Yeah, so great point. We need ideas that solve problems. So I would open up by clearly saying, what problem will this solve, right? Whether it's a cost problem, a quality problem, safety problem. And so, automatically say, hey, I think we have a problem with this. I think I have some ideas how to solve it. The other piece, I would diffuse their negative biases. So each different role has like a pet peeve in when you raise a problem. So CFO is, it can't cost more money. Docs, it can't take more of my time. Nurses, the burden can't all fall on me. And whenever I go into these exercises, I do what I call the pepperoni pizza exercise, where each piece of pizza is the stakeholder and the pieces of pepperoni is what their pet peeve. So if those people are all in the room, I immediately say, and I know all this can't fall on the nurses, it can't take more time for the docs, and it can't cost more money. Those are the constraints we have to solve it. In presenting it, Ross, there's the most powerful acronym for presenting ideas that I've ever heard, and the acronym is PCAN. I read about it in a book from a Wharton professor on effective communication. It's called The Art of Woo, but this piece is, I think, by far the most important thing. And whenever you're presenting, the acronym that I use is called PCAN. It stands for problem, causes, answer, net benefit. So right now, so we're using one now. Our OR supply costs are through the roof. The cause is we don't really have a good management system. The surgeons don't know what things cost. We haven't standardized our preference cards. We open things before asking because our staff, the nurses, don't want to get yelled at if something's not ready. Okay, so the answer is we're going to put a team to look at this. We're going to create a culture that we make it safe, that the surgeons say, don't open it until I tell you to. We're going to revise our pref cards So these things are PRN, not whatever that is. And then the net benefit is we think this is going to save this much money or it's going to reduce harm. Could we move forward for this? It's almost foolproof.
No, I mean that's great advice, and I
The one
really
thing I
like
would
the
say,
approach
if
of it.
your listeners try it, they have to email me and tell me if it works. Like
That's
it's really,
fair.
I mean, it's really evidence based. So
No, I
problem, cause, answer, net benefit. I mean, Ross, it's so powerful. Like if I'm doing a talk off the cuff, like my brain just thinks pecan. I just think, okay, open what's, because otherwise you could ramble, you get lost. People are busy, they have a short attention span. They don't want like this, long story about how you got there. Lazily focused. We have a problem with this. We think these are the causes. Um, Here's what the answer is. And it's okay not to know the answer. The answer, you could say, I don't know how to figure this out. I just want your permission to say, could we go explore what that answer is? We'll put a team together.
no,
Um,
that's fantastic. That's great. Pecan. Now it's in my head, so now I'm gonna be
yeah,
walking around with that
good.
because I'm gonna
One
use
thing
that.
for those of you who are in leadership positions, or if you have someone who does it, I think one of the most destructive leadership behaviors for destroying innovation is telling a junior person or someone else, don't come to me unless you have the answer. Like, I mean, like literally, I would say if someone keeps saying that, they wouldn't be working for me. Like, it's that destructive because, like, a junior person, so Julie just out of residency and starting a fellowship, you shouldn't have to figure out how to solve the problem. Like, that's like, that's my job to get to the resources, or, I mean, you may have the answers and you often do, but it shouldn't be a condition for having your voice heard or surfacing a problem. We want a culture where Julie's bringing me all these problems, right? And then we would say, okay, let's get a team of who may know a way to solve it. It's often not one person, but a team of people who are close to the work. But I would never send someone away and say, don't come to me unless you have the answer. It's destructive and demoralizing.
I think that is such a wonderful sentiment to hear coming out of a C-suite leader, and exactly what we're trying to share with our membership, that it's not such a scary thing to talk to your C-suite, and that it can be this incredibly productive relationship, and just how do you approach it and make it most kind of beneficial for all parties involved, so no one's wasting each other's time and you feel like it's a net positive for everyone.
Right.
So I love that framework.
Yeah. And Julie, on that note, just remember, the C-suite has a board who they have to look well and they're facing problems. So just think how, through this framing it, how do you make them look good? Because this isn't ego, right? So you taking cost out of the ORs or whatever, is you billing better in the OR, reducing complications is going to help solve a problem that's relevant for them.
Sure, absolutely. Kind of in that vein, in your role as Chief Quality Officer, how do you think about and define the concepts of quality and value and ensure that you're having a shared vision with individual employees and kind of the greater institution?
Yeah, great. And so, just under my portfolio, so I run quality, which has patient experiment, safety, policy, regulatory, risk, infection prevention. Then I run our ACO, so all of Pop Health and the care managers and responsible for our managed care contracts and performing. I also have all of care coordination and the care managers, and that includes home health, physical therapy, a variety, social workers, a variety of other roles. And then I have our operational effectiveness, so getting rid of clinical variation, and I run an innovation institute. So I say that because how do we inspire the whole organization to be aligned around something? And so we kind of frame it as in a number of ways. One is we want to provide the highest value care for those who provide care, receive care, and pay for care. I mean, the employers, because all of those we have to do it. Most of our employees' value is like an abstract word. So the really simple way we communicate it, Julie, is that I know you're doing that if you're working to keep people healthy at home rather than healing in hospital. Like really that simple, right? If directionally what you're doing is, so that could be shortening length of stay, avoiding inappropriate ED visits, preventing readmissions, getting healthy behaviors. And, we group those into what am I doing for preventative care? So those health behaviors, annual wellness, what am I doing for chronic disease? So for any chronic disease, we have a framework of measures that say, am I accurately diagnosed? Because half aren't. Am I on guideline recommended therapy? Have I controlled my physiology? Have I screened for behavioral health and social needs and referred? Have I avoided ED visits and hospitalizations? And then on the acute side, how well are we managing all this safety and harms? And we use those 4 measures of harms that I mentioned before. So zero physical harm, zero suffering from disrespectful care or waste, or excuse me, waiting, zero waste, and zero inequities. Julie, to one of the insights into your question is, I think so often we think we have to be just scientific, that we leave our hearts at the table, but the reality is, I think in this work that the heart motivates and data documents, right? I'm hardcore on data and analytics, but people don't get inspired. Like we our cancer center, we looked at time between steps in a woman's breast cancer journey, and those are often invisible. So mammogram to biopsy, biopsy to path report back, path report, to getting some definitive therapy. And as you could imagine, there were huge gaps. I mean, a lot of patients, they fall through the cracks. We don't have a good heart. And then standing in front of our on team and writing about it in our organization, saying, when you are sick, and especially when you have cancer, waiting is suffering. And there's no other word for it. And we are causing suffering by not having hardwired systems and service standards to respond to people, right? And that motivated that team to and they completely reorged how they did things. Like their wait times are down now. They made these visible. They redesigned it out. But if I had gone in and just said, you could be 200 days to start chemotherapy or whatever it is, you could have long wait times, would have probably pushed back on the data because of course it wasn't perfect. And, what am I doing, as opposed to saying, yeah, here's some signal that we're causing needless suffering. And here's some stories from patients who said what it was like to be waiting, to get my path report back, and the anxiety. And so I think for us to remember the human side of this is really, really key. Julie or Ross, one other piece that I think is also really key for your audience to remember is, burnout is real right now in healthcare, right? I mean, it's half or 55%. And, I know many health systems are having people do better self-care, which I think is deflecting the problem. Like that C-suites, we caused it because we didn't reduce your pain points. The EMR caused a lot of it, or the systems that you have to work in. But what's been neglected in this discussion is that working on a meaningful quality improvement project is not just joyful, it is the antidote to burnout. Like I can't tell you, when you've probably seen it or you've been engaged, when you have a clinician who their voice is respected, they're solving a problem, they see it getting better. I mean, it is they're effervescent. I mean, effervescent, they're buzzing, they're joyful, and it's extra work, but it doesn't feel like work to them because they're in the zone. I mean, and I see you smiling, Julie, so you probably felt that as a resident, people, I'm solving problems, I'm making an impact, because all of us went into healthcare to make an impact. And so I think as leaders or as organizations, we need to recognize that this isn't just solving a problem, this is soul food for our doctors and nurses who are so desperate in need of it. And it's yours for the taking. Fixing the EMR, yeah, we can tweak it around it, but it's a pain in the ass. It may be out of our things. Getting involved in an improvement project and solving a problem is yours to go. I mean, there's plenty of opportunities around to go fix something and make it better.
I mean, this is all. Julia, go ahead, please.
No, I was just going to say it really resonates. And, as graduating chiefs, one of our requirements is that we had to do a quality project. But the institution overall sends out kind of quarterly emails where you can submit what to fix suggestions. And then the people build it out with IT or whatever groups they need to work with. And they then kind of promote it to the whole institution, like, oh, this individual person who saw this problem made a suggestion and this is the path I went down and this is what we're doing differently now. And it's like so impactful to see that, even just in an email. Doing it yourself is much better, but
Yeah, no, you're absolutely right. It's you know, Julie, just on that note, one other point. There's so many things that we could talk about. Oftentimes we talk about how we need to change the culture, right? And I'm sure you probably like many ORs are not friendly places or they're contentious places, needlessly contentious, and or whatever it is we feel we want to change the culture. But our mental model is the culture is outside of us. It's this whoever these anonymous people, maybe the C-suite, who create culture, and we're like the passive recipients who just have to live in it. And I would encourage you to say, you are the culture. We are the culture. We make and build or break culture every day by the behaviors that we choose to do. And I'll share with you, rather than think of it as this like, amorphous thing, you shape culture or we shape culture by what I call the 5 R's. And the first is our role modeling, how you behave in the OR. So do you open your timeouts with saying everybody's voice matters, I want you to speak up. We shape it through our rhetoric. Words matter greatly. The way you speak with people, and especially if treating people with respect, which should be always, or using words that imply power with rather than power over others. We create culture by our recognition, what you just said, Julie, that sending out that monthly or quarterly email, really important, recognizing those behaviors, that we get more of those things. By our reward systems, and as you all know in the OR, by our rituals, right? And ORs are probably the most pageantry rich rituals every day, but we can make them like to celebrate the team or do things that could pivot the culture so that it is the more of this, this generative, positive, energizing culture rather than, a judging and a shaming and a punitive culture.
I think that's really important. I smile because also it's like I can say like at our own hospital we have this kind of program called the Speak Up Awards, which comes from the C-suite. So we people get written for even the smallest things that they do, helping out a family, going above and beyond, or having an impact on the system. I get to participate in some of them with our C-suite. So one of our nurses in the OR found an error with our IMED consents about there was the names being projected wrong on kids, brought it up to someone, raised a concern, ended up changing how the whole system did everything. And so they rewarded her by we have this little ceremony, like a scheduled thing for like 10 minutes. The whole C-suite comes down. Just of course the employee freaks out because they don't know why they're being brought up in front of the whole C-suite in the OR, but they're just want to say thank you. Give them a certificate, give them a little gift card to Amazon for $100, take a picture with them, but just thanking them for speaking up and just not being afraid to bring change forward. So I think that's right in line. We have these little ways. It doesn't have to be a big thing. You don't have to change the world with every move, but just showing that support and acknowledgement, I think is you're right on there. That really just breeds more energy and desire to make change.
And Ross and Julie, it doesn't have to be C-suite. Like your audience
Yeah.
should be doing these, right? Those 5 R's are really simple. I mean, just imagine like being mindful of the rhetoric you use or the rituals you create in your ORs every day, or like I can like in the ICUs, I routinely start rounds with just asking, does somebody want to recognize a teammate or a colleague who did something above and beyond, either for them or for a patient, right? Just totally sets the tone of of or we have a breast surgeon who has a ritual of when people are going to sleep, she holds their hand and tells them they're going to be safe. And I get more positive notes out of from that, really simple, powerful ritual that it makes a huge impact so that we all can make, do those 5 R's in our own sphere of influence and make your day more joyful and the teams you work with more joyful.
No, I think this is great. So let me ask you, change the direction a little bit, because we've talked about how you've interacted kind of with the staff and the multiple hats you wear and kind of going downwards. So you are still part of the executive team, though. So within that team itself, curious about best practices you've learned about communicating goals and working with others kind of at your level or even higher, the board. Just so you've talked about kind of us coming from, to work with you and you working kind of down with the staff and the frontline people. What have you found when you have to work with your kind of your peers at your level or at the boards even that you have to report to?
Yeah, so great question. In many ways, it's the same thing that we are trading multiple risks and things that we have to manage to. So that though something may be my priority, that other executives have their priorities and they're important, and the board has, kind of integrated all these. So being mindful of that just because it's my priority doesn't mean it's not important to others, but they may have other things that are. Second is, I think that we underestimate the power of leading with questions. So to ask, well, tell me, so what are you worried about, or how could I, um, uh, you navigate this? In just like I said earlier, our CEO, like all CEOs, needs to look good in front of the board. So I see a big part of my job is to make sure that the CEO looks good in front of the board, right? It's not about me looking good. It's solving a problem that makes a difference, for the uh, 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 CEO. And then, one kind of simple metaphor, Ross, that I think is helpful is this concept of aperture. In other words, how wide is your field of view, or meaning how much information do you take in um, when you make a decision? And so, like, one aperture could be a tactical, strategic, visionary. Another aperture could be, doing things to people versus co-creating, a solution together. And what I think we need to all try to do is get as broad of an aperture as we could to make sure we have this diverse perspective coming in. But then wisdom is knowing what level of aperture do I need to be at. So like I'm at some big problems and I have a vision, but the reality is like I'm not building my, we have docs who aren't dropping code. So I like get really tactical and go drop down to 100-foot level to solve a problem, right? And then I'll pop back up, and having that insight to say, okay, I can broaden the lens, but right now, like I need to get really focused, or get, come down to whatever level it is, and then I might broaden it out again and go back down.
So hope you don't mind. I'm taking notes because I'm trying to get everything I can out of this because I'm going to use it myself, like starting tomorrow. So that's why you may see me every once in a while just writing stuff down because this is fantastic. This really is. This has been these questions, these answers are fantastic. I'm going to kick it back over to Julia though. I know more for you.
I have kind of a twofold question. Both, what do you, in your role as Chief Quality Officer, wish that individual clinicians brought to you more frequently, or they knew about how to bring things to you? And then for the kind of pre-clinical practice individuals, the residents and the trainees, are there any specific resources that you would refer people to understand a little bit better kind of how a clinician interacts with the world of quality?
Great. So, what I wish is that, people at the front lines would bring me more issues, or would speak up and raise issues, or we had more forums to hear their voice. Problems get solved from bottoms up grassroots solutions, right? They don't, hardly ever get solved from, a top down, unless it's like a regulatory mandate that we have no choice, or we're going to lose CMS funding. I think from the mindset of the trainees, I would both encourage them to see that their agency, like they have voice, they have power, and to speak up. I think too often they either feel powerless rather than powerful, and they don't implement change, or they're cynical and just like assuming positive intent. Many frontline people, and perhaps you can say it's justified, don't have positive intent with their C-suite. So they, think they're jerks, so they're never going to listen. And I religiously require that anyone like under my portfolio treats people with respect all the time. Like we would move people out of their roles if they can't build trusting relationships, they can't do their job. It's literally that simple. So we don't tolerate those kind of people who can't make it safe to speak up and to build trust. So all these relationships are bidirectional, Julie. We both have our biases. I think both sides need to assume positive intent and trust each other. Believe me, some C-suites, as you probably hear, have conceived notion that our docs are lazy. They're just they aren't working hard, and so we use this phrase, Julie, in all of our work that says change progresses at the speed of trust, and trust grows when we do things with rather than to people, right? And it's probably the most potent thing for improvement to remember. So, like when I was doing the checklist, there was a ICU leader and nurse leader came up and said, "Peter, you're going to be so proud of me. I took your checklist and I went to my staff and said, you will use this checklist. This worked at Hopkins. You're going to use this." And I said, "Boy, I bet you that went over well." "Well, no, they pushed back, but I'm going to push back further." I'm like, "No, please don't do that." And so I literally said, do not call this the Peter checklist. Do not call it the Hopkins checklist. Call it your own hospital's checklist. And do not use my checklist. Say, these are the 5 things that are important, but let's make it better. Get your team to co-create it. Do things with them rather than to them, right? And quite frankly, that simple shift is why I think it worked, because too often we tell people how to do things rather than keeping our focus on why and what and engaging people to co-create the how. And then remind me your second part of your question.
It was just asking specific
okay.
resources, but
yeah. So
I think
for the trainees, this may be one of the most important insights for your career growth is try to be a jellyfish more than an elephant. And what I mean by that is most of us in our training are like elephants, where we have one long methodological or technical skill, right? In this case, it could be bariatric surgery, and we know preciously little about anything else. But the reality is the problems that we need to solve today are almost never solved within one discipline. They're solved at the intersections of disciplines. And so much of medicine is organizational change or human behavior. In other words, it's social sciences, but most of us get essentially no training in social sciences. So we get to be leadership roles, you're leading teams, but we don't have a clue about what is teamwork meeting or organizational theory or behavioral economics or social psychology. And so what I mean by being a jellyfish is you need one long methodological tentacle. So like you need whatever your training is, but then you need many short tentacles like a jellyfish to get curious about. Like, so for example, in the Armstrong Institute, we had 19 different disciplines represented from every school in the university. And we weren't experts in them, but I knew enough to say, oh, this is a behavioral economics theory that I can use to drive change, or this is a human factors theory, or this is an informatics concepts, or this is an organizational theory or an economics theory that you draw upon to just get curious about how human behavior changes, because that's all this improvement is all about, human behavior. And like, I'll give you an example. We in our ACO were sending out communications like every hospital does to encourage mammograms or colonoscopy or get followed up, and the kind of the unimproved way was, hey, you need to get your mammogram. And the social psychology literature is really clear that if I send out a message that says stop speeding, it makes people speed more because they think everybody's speeding. Why am I going to slow down, right? And so same thing, get a mammogram. Well, no one's getting it. Why should I do it? Because we respond really clear to norms. Whenever you send a message out, we always make sure that the social norm is everybody's doing it. So if I had a mammogram, the message is worded, most people like you have had a mammogram and you have not, and it increases your risk of harm. Click here to schedule. Or if I have a professionalism amongst our colleagues, I know not amongst our general surgeons, we all know that they behave like angels in the OR, but is we would, instead of saying like stop being a jerk, right, which would worsen the problem, it's always very clearly most of our physicians treat people with respect or professionally, but a small group of us don't, and here's what's going to happen like if we do. But norm towards the behaviors that we want, and most of the time that's true, Anyways, that's just an example. So get curious and like, read, things about like, quality, read things about AI, read things about, informatics. Julie, one final thing is why I'm so hopeful about you raised up the learners. The students now, even in med school or early residence, will be the first generation to be AI natives, right? And most of my age, or certainly our organizations, are approaching AI from fear rather than hope, right? From scarcity rather than abundance. But your generations have been using it. I mean, Frank, I use it like 5 times a day, whether it's open evidence or just Chat GPT or Copilot. And I think having a group of learners who think about the ability for technology to solve problems is we are going to solve problems better, faster, cheaper. And I think the younger generation is going to be doing reverse mentoring for the older generation. So I'm looking forward to the students and the early learners to be my mentors. Just they have to have patience and compassion with me.
I think that's a great way to kind of summarize everything, go full circle. This has been really beyond fantastic. We've been so happy to have you on. I mean, on behalf of our entire Sages Lead Up Task Force, we thank you for taking the time to impart some words of wisdom. We appreciate the energy. I'm hoping that all our listeners really get a good glimpse of kind of what you're looking to bring and the ideas behind it, with some ideas on what they can do with their institution. Really, thank you for taking time out of your such busy schedule, because we know how busy you are, just to give us some advice and to improve communication with someone in your position or the C-suite. Really, just thank you for taking the time. It's greatly appreciated.
Yeah, and Russ, if I could just leave your words to say, like, all that you need to make this change is within your people now. It's why I say the secret of great care is love is basically respect yourself, be compassionate with yourself, and respect others as you're going around solving problems, and you will make the world a better place. And remember that it's not that we need the answers, we just need the courage to ask the questions and to convene the people to figure it out.
That's the best way we could end this. Thank you so much. This
Absolutely.
is great.
All right, be well.
Yes,
Thanks.
thank you so much for your time.
And that concludes today's Walk in the Park episode. We hope that today's discussion provides you with both resources and motivation as you lead up in your practices and organizations. Follow us on X, Instagram, or your favorite social media platform at sages_updates. Tune in again next time and reach out with any thoughts on how to improve the podcast. We are open to suggestions. See you next time.
What do you call a sleepwalking nun?
What?
A Roman Catholic.
Ah, wah, wah. Love it.
I don't have any jokes because my entire life is a joke.